Hi, I'm Kathleen Hernon. I am the Director of Clinical Informatics for Partners Healthcare at Home. I'm a registered nurse, BSN. I have been in home care for over 30 years. And I also chair our emergency management group and EOC. As far as Partners goes, I'm just going to give you a little bit of background for Partners Healthcare at Home. We have an average daily census of approximately 4,500 patients. And we have a clinical staff of about 650 clinicians and overall staff of nearly 1,000, and that would include our business operations, finance, and billing teams. As you know, as we were notified back in February of this potential COVID pandemic, the Partners Health System, which is comprised of our academic centers, Brigham and Women's Hospital, Mass General Hospital, as well as multiple community facilities, ambulatory and outpatient sites. We have a Partners Emergency Preparedness Committee. And back in February, we activated our emergency operations center at a system level. Each of the facilities, including Partners Healthcare at Home, did the same. So we each have our own individual groups, and we, work with the system. That system level EOC became very important during this pandemic. It gave us all the opportunity to come together and to discuss, collaborate, coordinate care across the system. I think that our leader, Paul Bittinger, who is an emergency room physician at Mass General and chair of our PEPC committee, did a phenomenal job and still does. We still meet weekly as for an incident command to continue this work. One of the things that came out of this from a home care perspective is the incident command team needed to understand how the pandemic would impact patients in the community. And so it was a little bit different for our clinicians, and we needed to be able to coordinate with the system to ensure they understood that. One of the challenges that we encountered initially really was all of the CDC changes around infection control and, PPE to use and how it was going to be used and managed at the inpatient level. And then how are we going to be able to manage it in the patient's homes? We wanted, there were three goals, really. One is to ensure patient safety while delivering care, right? We still need to deliver care. Two was to ensure staff safety. And three was to reduce the risk of spread. And so we worked very closely with the infection control team at the system level. We wanted to educate them on what our needs were. We, like everyone else, had challenges with obtaining PPE. And we needed to ensure we were able to, distribute, well, first of all, obtain and distribute across our multiple offices. We have 5 main offices, which staff frequently, access. And so we needed to be able to do that. And we did that successfully. One of the things, which is kind of just an interesting sidebar, is when we were speaking to masks and the reuse of masks and the N95s and getting everybody fit tested and the challenges around that, and we were able to use some redeployed staff to be able to do that piece. And so in trying to do fit test every 650 clinicians, it was a bit of a challenge, but we did that very successfully. We then had people, different people, myself included, going out and just kind of shopping for brown paper bags to keep these masks in the car so that they could be reused. And so we had to, look at some of those CDC guidelines around that. And we were able to do that. And we actually, as a team, were buying thousands and thousands of paper bags because we just couldn't get them delivered quick enough. So with that said, I give kudos to all of Partners Healthcare at Home, the managers and the nurses and the therapists and everybody who actually pulled together to ensure that we had the equipment that we needed. One of the other upside of being part of a system was access to PPE. Like I said, it was a challenge, like everybody else, to have deliveries, and we were able to tap into the partners' cash for some of those supplies that we needed. When I talked about, the goals, I have to say, just like you heard on the news, and we heard across even our own system and other hospitals, systems, etc. The people were scared. Staff were worried that they were going to bring, COVID-19 home to their families. And so we worked very closely with our HR department and provided ongoing education and support to the staff to try to alleviate some of that stress. I think that staff overall understood the work that was being done behind the scenes to ensure their safety. I think that overall they appreciated it. I do know that during that critical time, like March and April, when, regulations were, well, I shouldn't say regulations, when recommendations or guidance was changing so quickly and rapidly, that was a huge stressor for the staff. We are now in a much better space with that. That things seems to have kind of stabilized as far as what they need to care for the patients. And it's almost like routine at this point. One of the things I do want to mention is the volume of patients that we have taken care of and continue to care for. So to date, we have cared for 797, so nearly 800 COVID positive patients, along with 774 COVID risk patients. All of those patients require PPE. So that's over 1,500 patients. On service today, we have 15 COVID positive and 19 COVID risk patients. At our highest level, we had nearly 300 COVID positive patients on census at one time. And there were certain teams, of course, because of hot zones across the state, that had to endure, dealing more with that patient population. And so we ensured that we really paid attention to those staff with a lot of manager support and the clinical directors supporting those teams. So first of all, I think that from a partner system standpoint, I think they were right on top of it. They were looking at this very, very closely, and they actually started to really talk about it and pay more close attention to it come beginning of February when all of this was happening. We actually were having some other issues, like vendor type issues, with a different note, and they started to weave this in just to kind of bring it into the forefront. For me personally, when it hit home, I had been participating in the meetings, had seen some of the news, and I went onto YouTube and I actually watched a YouTube video of what was going on in China. And I had this almost moment of anxiety, I have to tell you, as I watched the video and saw what they needed to do and how they were actually handling all of the patients and the cases in the building of these new hospitals, within weeks, and the hazmat suits in the community. And I thought I really had a moment of anxiety. And that's when it became real to me, really real to me, that our entire world could change. And so that was that was like an aha moment to me. I think from a system level, on the big picture, I think most of the leadership teams, whether it be in our home care and at our hospital enterprise level, they all thought that this was real. But I think that, and we were planning on dealing with it, but there was a sense of urgency, more urgency than under other events. We've dealt with Ebola, we've dealt with other influenza type things, and we had travel screening already built into our documentation and our charts. But in reality, things moved so fast that we ended up having to turn on a dime with things. And that piece alone was very different from an emergency planning than I've ever experienced. And I've been sharing emergency planning here for probably, I don't know, close to 15 years, I bet. Well, 10, 15 years anyways. And so that was very, very different. So there definitely was a burning platform. And we had to quickly make decisions that we felt were best for the patients and the staff. And then we had to revise some of those decisions as we moved along. But I think overall we did a good job with that. I don't know that we really had, I don't know that we really had a lot of pushback. We had a lot of, and pushback meaning people who didn't want to use PPE or of that nature. I don't really feel we had a lot of that. We had more anxiety, I think. Staff wanting to do the right thing for the patient, wanting to do the right thing for their families. That's where we really saw some of the stress of this. And of course, the other thing was, adding all of these layers of PPE, the donning, the doffing, and the impact to their day and the time it took to take care of the patients was extended. So there was concerns around just even their productivity. How many patients can I see in a day? There was stress around that as well. We did see a decline in our census during that time because we had patients who they didn't want us to come. Then, of course, there was the whole piece with the hospital systems not doing their surgeries, patients not going to the ED, ambulatory practices, closing, closing temporarily. But anyway, so that reduced some of our census, which I think actually helped the staff. We did initiate some new tools. So I talked a lot about PPE, but there's a couple of other things that we did as well. So I mentioned the fact that, in our clinical records, so we're electronic, all right, of course, and so in the clinical record, there was a screening tool, but it really didn't include all of the factors that needed to address a COVID. So we actually created a new tool in the system. And at a system level, that was going through some revisions as well, like the ambulatory questions versus inpatient, et cetera. So it was a bit stressful. That was something that was added to the staff. I mean, they needed to, when they were calling a patient to make their appointments, needed to ask particular questions, and they needed to document it in the record. And based on that documentation, we were then able to flag patients if they had been tested outside of the system with a banner that said they were COVID positive or COVID risk, because in those who were tested in the system, that was kind of an automatic thing that happened in the chat. So there was a visual for staff to know what they were walking into when they looked at the electronic patient, the record. But that added a level of stress too. There was a little bit of pushback. Staff, I can't say they didn't ask the questions because I'm sure they were asking the questions, but we found some documentation in different pieces of the chart. They didn't like necessarily using the tool all the time, but we did have good compliance with it, but that was a bit stressful and it was new to them. So that was a bit of a challenge as far as that went. So I don't necessarily feel, like I said, that we had a lot of pushback as far as the right thing to do. It was more anxiety around the right thing to do. I think some of the things that we've learned, so we did a lessons learned and a gap analysis and all of that, and that's actually ongoing work. So we have focus groups that are looking at key areas where we felt like, you know what, there's always opportunity to improve. Okay, I always feel that there's opportunity to improve. So kind of key areas under like operations, metrics like data analysis, communication, is another key area, and then policy and procedures. So communication, you know, I think is probably one of the biggest challenges of any business, whether that be healthcare or anywhere. Communication is a challenge. For home health, because staff are not in front of you, it becomes a bigger challenge because you are always needing to communicate via email, you know, huddle calls, staff meetings, newsletters, everything. Staff felt that they were being bombarded from all over the place with communication. So one of the things that we learned is we needed to streamline things a little bit better. So that, and that's something that we're working on right now. And, you know, that's going to help us from a resurgence standpoint, but it also helps us just from emergency planning and preparedness overall. And so, you know, we had to take a step back and say, yep, the communications were necessary. Could we have done a better job at how we delivered the messages? And I think, yes, we could. And so we're working on that. That's key. From an operations standpoint, one of the challenges that we had was really looking from like data, like, you know, really understanding the impacts to your teams and looking and saying, okay, I have X number of patients on a team. I have X number of clinicians. And if I have clinicians who are out, you know, whether it be, and this is part of the resurgence planning, what if they're out because of COVID or they're just out because they're sick or LOA, you know, they have a day off. They have childcare issues, whatever it be, is really looking and saying how can we do a better job at reporting so we understand the impact to our team, and do we have any challenges around capacity management and how do we share staff, things of that nature. So I think the clinical teams, we have I think 17 or 18 clinical teams, and they do a really good job communicating with each other. To help each other. But when you go and you look at it from a leadership standpoint, I think we need to do a better job at how we can look at it from a big picture and say what's going on organizationally. So that's something else that, you know, we're really looking at. Policy and procedures. I mean, that actually is just kind of tidying things up, you know, based on some of the changes, and trying to streamline where people where staff can actually access information. So we've done some work on that where we had separate policies and we kind of combined things. So it's kind of one-stop shopping, utilize some electronic tools so you can actually search by particular words or have links that jump you to different areas of policy and procedures just to make it easier. So there's that piece. The other piece too, when and I'm kind of jumping a little bit and I apologize, but the other piece too, I go back to like the staffing and the patient pieces, we're really taking a really close look from a metric standpoint at the state data. So, you know, it's one thing to be in the middle of the crisis, right? But we want to be planful and say, oh my God, we're starting to see data trend. And where are we seeing it? What hot zones are we seeing? Are we starting to look at it? And we're looking at things from multi-levels, all right? One is system data that we're now getting, looking at the emergency room data, those that are being tested and are positive in the system. You know, which towns, which hospitals, where can we predict an impact that now we're going to see additional patients come through the door? You know, for referrals for home care. We're also looking at the state data. You know, what are the hot zones? Where can we be prepared? How do we get the PPE ahead of time and make sure that we're stocked appropriately so staff don't have to worry about that and keep that stock up? So all those things are going on right now. We also look at our internal. We actually report out every day with internal data that goes out to our entire leadership team. It's broken down by team so people can look and say, oh, I can see that, you know, team A has X number of patients who are COVID positive today. Team B has X number, et cetera. So we can kind of see that. They can work with each other if we're seeing spikes So there's a lot of analytics that's taking place to help us actually work through the day-to-day needs as well as prepare for resurgence. The other thing I'm going to mention in preparing, and this goes back to kind of February, one of the things I think we were in very good shape when we had to go to a remote workforce. So, you know, first of all, clinicians are remote, right? So they have the electronic chart, they can sync data, et cetera. But you have many business operations. And last year, we made a concerted effort to get laptops for all of our business operations. And that was mostly because of working during our environmental problem, like, you know, storms, blizzards, etc. And, you know, people like saying, you know what, you can work from home, because you really could do all of our work from home. So we were really well situated, and all departments were able to work remotely. And that would be orders tracking, our, intake, referral process, billers, I mean, all of that. So we were in very good shape for that. So I'm glad that we did that effort last year. So we weren't scrambling this year. We did have to, you know, get a few additional cell phones to people. But otherwise, I think that we did a really good job with that piece. Right now, we're kind of a mix, right? So as Governor Baker kind of lifted some of the bans, we started to have some staff come back in working in accordance with the state guidelines. So we actually have a mix now, but I can tell you that probably, I don't know, maybe 80% of the staff is still remote. What we are doing, we ensure that we have, and even during when everybody was remote, we, for the, you know, well, actually, once we started to be able to go back into the office, so I guess it was probably the beginning of June, we ensure that there is leadership in every office. So whether that be, the clinical managers, there's the directors, and we switch off. So I'm in the office 1 to 2 days a week, and my counterparts as well. But we make sure that we have a presence from a leadership standpoint in all of our offices. We do have to, some of our departments, we've brought back several staff, but most of them are still remote. Like part of the schedulers are working in the office part of the time, and then they rotate and they're working from home. And that remote work seems to be going quite well. If it wasn't, I could say that, we would be approaching it very differently. So to answer your question, about the future, I think it does change the way that we work. I think that we will continue to have a percentage of remote workforce, whether it be being partially remote and then partially in the office part of the time. I do think that it does change how we work. I think there are a lot of businesses out there who are thinking the same thing. Fortunately, we have great staff who are responsible and accountable. Like I have a team of 10, and they're working kind of a mix of remote and in the office. And I fully trust and can see they get their work done. So very vested employees, and I think that's how it makes it work for us. When I mentioned the, there were, patients who were anxious about us coming into the home. We did virtual visits. That's a really big piece. Okay, so I didn't mention that. So, we instituted virtual visits, utilizing Zoom and FaceTime, and we ensured that it was all HIPAA compliant and all of that. We have an electronic record, for the patient that they can go in and see called Patient Gateway. A lot of work has been done to be able to do virtual visits through that Patient Gateway, and we're kind of moving in that direction now. Because that for bills for home care just took a little bit longer. So, but anyways, but we've done virtual and telephonic visits and have provided probably close to, 3,000, of those in this time. And of course, it has diminished some over the past couple of months. But that was key because for patients who, were nervous about us coming into the home, we had an option for them. And, some of them, as long as they electronically could handle it, whether it be through a family member or themselves, they were, most of them were quite open to it. And so we were able to provide that care for all of our disciplines, of course, with the exception of home health aid. So, and it worked quite well. And so we're continuing, when you ask me the question about working remotely, you have to take a look at the delivery of care model, right? And so, this actually, the pandemic is horrible. It's horrible, all right? It has opened up a new way for people to think about how they work, right? I mean, just you and I doing this, right? Not in person and having to travel to do it, and being able to have virtual meetings and being able to provide care virtually to patients. Not all patients can that be done, okay? We know that. But it just allows us to be able to put our eyes on a patient without needing to take the time to travel, and to be able to triage that care. And I think that is not going to go away. I think that is going to become a part of the new care model, whether it be for the ambulatory practices, for your PCP visits and things. I don't think it'll be the only way. I hope it's never the only way. But it's going to weave into the way that we deliver care for the future. And so we continue to work at that with our clinicians and look at the clinical model and say, where do we have opportunities? So from a vision or strategic planning standpoint, where are opportunities to kind of intertwine some of this new technology, so that we continue to provide care and reduce the level of stress on the clinicians?